Moderated by Professor Manjeed Malik, and I request Dr. Abdullah to come on the podium and recite few verses from Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. तर्जुमा समाअत फरमाएं। वल अस्र, कसम है ज़माने की, इन्नल इंसाना लफ़ी खुस्र, बेशक इंसान दर हकीकत बड़े घाटे में है। उसमें आगे अल्लाह ताला फरमाते हैं सवाए किन लोगों के, इल्ला सवाए इल्लल्लज़ीन आमनू, जो लोग ईमान लाए, व अमिलुस्सालिहाती, और नेक आमाल किए, व तवासौ बिल हक़्क़ी, और एक दूसरे को हक बात की नसीहत की, व तवासौ बिस्सब्र, और एक दूसरे को सब्र की नसीहत की। जज़ाकल्लाह, सदक़ल्लाहुल अज़ीम।
Thank you. Then Bismillah करें. Not Rasul Pak from Dr. Abdullah.
सल्ले अला रसूलना सल्ले अला मुहम्मदिन सल्ले अला नबीना सल्ले अला मुहम्मदिन सल्ले अला करीमिना सल्ले अला मुहम्मदिन हादिये बरहक रहबरे आज़म सल्लल्लाहु अलैहि वसल्लम सल्लल्लाहु अलैहि वसल्लम उसवाए कामिल रहमते आलम सल्लल्लाहु अलैहि वसल्लम सल्लल्लाहु अलैहि वसल्लम बादज़ यज़दा बालाओ बरतर बादज़ यज़दा बालाओ बरतर हर एक नौ से सारे जहाँ से हर एक नौ से सारे जहाँ से अफ़ज़लो अकमल बशरे मुअज़्ज़म सल्लल्लाहु अलैहि वसल्लम सल्लल्लाहु अलैहि वसल्लम मुहम्मद अहमद शाहिद हामिद मुहम्मद अहमद शाहिद हामिद तैयब ताहिर आदिल आलिम, तैयब ताहिर आदिल आलिम, आका ओ मौला नबी मुकर्रम सल्लल्लाहु अलैहि वसल्लम, सल्लल्लाहु अलैहि वसल्लम। फ़क्र गना से रब की रज़ा से, फ़क्र गना को रब की रज़ा को, जूदो सखा को उफ़्वो अता को, जूदो सखा को उफ़्वो अता को, शाहे जहाँ ने रखा मुक़द्दम सल्लल्लाहु अलैहि वसल्लम, सल्लल्लाहु अलैहि वसल्लम। ख़त्मे नबूवत की निस्बत से, ख़त्मे नबूवत की निस्बत से, हर मोमिन पे फ़र्ज़ हुई है, हर मोमिन पे फ़र्ज़ हुई है, दीन की दावत कारे मुअज़्ज़म सल्लल्लाहु अलैहि वसल्लम, सल्लल्लाहु अलैहि वसल्लम। कामिल ईमान हो नहीं सकता, कामिल ईमान हो नहीं सकता, जब तक ना हो उल्फत आका, जब तक ना हो उल्फत आका, मज़हरी दिल में सबसे मुक़द्दम सल्लल्लाहु अलैहि वसल्लम, सल्लल्लाहु अलैहि वसल्लम। जज़ाकल्लाह।
Thank you, Dr. Abdullah, for making our morning very good with the hamd and name of Anhat Rasul Pak Sallallahu Alaihi Wasallam. Being the last day, some of our presenters are missing, some were abroad, they have come from abroad and they have left this early morning. Some other colleagues are from Karachi, except one are missing. So everybody has ample time for presentation. Happy good morning from all of us. And thank you very much for making this morning available for this session. I hope we will learn from all of you. So to start with, I will request Dr. Mazari, whenever you start cataract surgery, after incision, the next thing is capsule. And many things happen while doing capsular access. So run away capsular access. Invite capsule when it becomes an Argentina flag. So how to manage it? Professor Ziaul Mazari.
बिस्मिल्लाहिर्रहमानिर्रहीम। तो कितनी भी हो मुशाहदा-ए हक़ की गुफ्तगू, बनती नहीं है बादा व सागिर कहे बगैर, हज़रत गालिब ने कहा था। तो जितनी देर में ये अपलोड करते हैं मैं आपको एक गज़ल सुनाता हूँ और ट्रांसलेट करने की कोशिश करता हूँ। मैं से कुछ भी है गरज, हमको ना मैं खाने से काम। I am not concerned with the wine and with the wine place. आपसे हमको गरज, बस आपके आने से काम। I am concerned with you and your arrival. गुल का ही मरहून मिन्नत है गुलिस्तां का निखार, क्या भला गुल को हो मेरे दिल के महकाने से काम। अक्ल वाले कहते हैं क्या तुमको दानिश से है काम। शायरी वाले कहते हैं कि तुम ऑप्थेल्मोलॉजिस्ट हो, तुम्हारा क्या काम है शायरी से। अक्ल वाले कहते हैं क्या तुमको दानिश से है काम, कहते हैं अहले जुनू क्या तुझको वीराने से काम। और ऑप्थेल्मोलॉजी वाले कहते हैं साइंटिफिक सेशन में आगे शायरी सुनाता है। कहते हैं अहले जुनू क्या तुझको वीराने से काम। दीवानगी में यूं कहा करके मुझको मुब्तला, दीवानगी में यूं कहा करके मुझको मुब्तला, दीवानगी में यूं कहा, होश वालों को भला क्या होगा दीवाने से काम। ए दिले सादा फिदा तू किस पे जा आखिर हुआ, कुछ गरज जीने से तेरे ना ही मर जाने से काम। दिल ने मेरी और ना से की ना मानी कोई बात, कबल एडवाइज़र्स की कोई मानता है फिर। दिल ने मेरी और ना से की ना मानी कोई बात, है समझने से गरज उसको न समझाने से काम। हाले दिल की बात छेड़ी झट से आया ये जवाब, कुछ भी तो हमको नहीं है तेरे अफसाने से काम। जल के मरना है ज़िया ठहरा पतंगे का नसीब, द फेट ऑफ द मौत इज़ टू बर्न टू एशेस। जल के मरना है ज़िया ठहरा पतंगे का नसीब, शम्मा की लो को तो है इठलाने बल खाने से काम। एंड द कैंडल फ्लेम कीप्स ऑन डांसिंग एंड द मौत फेट इज़ टू बर्न एंड डाई। चलें, इतनी डोज काफ़ी है। रन वेयर एक्सिस, वो जो सारी एहतियातों के बावजूद जब बात हाथ से निकल जाती है तो फिर क्या करें। अर्जेंटीनियन फ्लैग साइन मैनेजमेंट। Hypermature milky cataract, our big concern is rhexis. If you are able to go through the rhexis part, rest of the job is relatively easy because there is milk all around. You don't need any hydrodissection. Nucleus is generally brittle and small. And in hypermature dense cataract, your main concern after staining and getting a good rhexis is with nuclear management, because the whole cortex has been nucleified and it's all mass of the nucleus all around. And if you are not well versed and not careful, the overzealous efforts to divide it and crack it may end up in zonular loss. So in this, we are concerned with milky type. See, the looks as good as always, and we always hope कि हम इसमें भी कर लेंगे, because you have done hundreds of such cases. Air bubble and the staining. Excuse me, pointer दे दीजिए दूसरे वाला. And so many techniques I promote and I always keep on teaching. So the tendency is to start with a small nick and to get the tongue as soon as possible. Tongue is when you evert the rhexis flap and roll back it on itself. That is tongue formation. Then the job relatively becomes easy. But because of the calcific nature and the other issues, I was not able to get that. ये क्या हुआ भाई? So there was a runway which I converted into rhexis. It's half of the job is done on one side. That is 1D formation. And again, deepening of the anterior chamber. The lesson always is, in any kind of anterior segment surgery, never operate or never manipulate in a shallow AC. So I am trying to convert the other half into another D. So that's done. So this is known as double D axis. That both of the flaps, the rip has been converted into a D on one side and D on other side, base to base, double D axis. So rest of the job is relatively easy because the nucleus is small, but you always keep in mind the quadrant where your capsule has run away. Be careful with that, and don't let extra stress come in that particular axis. Do all the cortical cleaning in slow motion. And there is an interesting sign which I will show you because we have time today. Most of the ex-Lahore and foreign speakers have left. That is fluttering flap sign. That tells us whether that runaway axis has extended beyond equator or not. I will show you later. So there is a intraocular lens being injected, and you see, sometimes it's not your day. The lens delivers outside the wound. So I have to reload it. And we inject it into the bag, and that same double D angles will be used to place the IOL haptic. That's a simple rule. You turn it 90 degrees away from the rip and place it in the bag. Rest of the job is routine, and wound is hydrated, and it's as good a phaco surgery as normal case, and hopefully it will behave well if we manage the runaway axis with double D technique, and we are able to place the lens in the capsular bag away from the axis of the rent. So that completes our first video. जी सर, अब क्या हुक्म है?
Sir, 4 of the presenters in the queue are missing.
So हम तुम होंगे, बादल होगा, रक्स में सारा जंगल होगा.
आप लेंस डालें ना, फिर हम आते हैं.
ठीक है. इसके बारे में कोई क्वेश्चन हो तो कीजिए. असल में ये वीडियो बेस्ड इंटरैक्टिव सेशन है, तो यू आर वेलकम विद एनी कमेंट्स और क्वेश्चंस. नन सर? If it extends beyond equator, no problem, because the nucleus is small, you can use visco-levitation. But how will you know that it has extended beyond equator? That is known as fluttering flap sign. The flap of the rhexis will flutter against the fluid current. If it has not extended, it will keep on moving. If the rent has extended beyond equator, the flap will kind of sadly settle on the nucleus. It will not move against your fluid currents. So that's known as fluttering flap sign, and I'll find in my laptop and show you later. So if it has extended and you have detected, give the cushion of the viscoelastic and visco-levitate the nucleus into the anterior chamber. There is no need to discontinue. You can shift to slow motion Phaco. Fill front and back of the nucleus with the viscoelastic, levitate the nucleus into the anterior chamber, and decrease the bottle height, decrease the flow rate, decrease the vacuum. And with the help of the second instrument and your Phaco, you can easily emulsify the nucleus in anterior chamber. And if nucleus is emulsified, then next step is slow motion irrigation aspiration. And Symco gives you better control. Just make it drop by drop, drop by drop. Fill the anterior chamber and the rented area with the viscoelastic again. The visco will keep on cushioning it. And it's Dr. Tariq Saeed used to teach it as dry aspiration. That those were the times of extra cap. So if there was endothelial compromise, he will always advise that take this case, he will award that case to a senior resident and simply say, do it with dry technique. And what we used to mean by dry technique was never let your AC collapse and your fluid ingress and egress should be equal. Suck as much of fluid as going in so that there is no turbulence of the iris capsule diaphragm. So gently you can suck the remnants of the lens matter, and if the vitreous has not prolapsed in the anterior chamber, you can simply place the IOL in the sulcus. Or if you feel the rent is small and both the capsular flaps will be able to support beyond haptic optic junction, that's the criteria. The remnant of the half of the capsule to support one haptic is haptic optic junction. It has to go beyond that. Then you can implant in the bag as well. But if you feel unsafe, just implant it in the sulcus and place the IOL haptics 180 degree away from the rent. And in this scenario, once that partition has been broken down, the vitreous cutter comes into play and it will be there whenever there is prolapse of the vitreous at any stage. You will cut it and proceed to the same step which I have already explained. And if it doesn't come, there is no need to bother vitreous. If it is not prolapsing in the anterior chamber, we will simply plug the gap with IOL and close it. In next video, I will show you that there was a posterior polar cataract, there was a central rent, and with the same criteria we were able to complete the whole procedure without bothering the vitreous. So I hope I have answered your question.
थैंक यू डॉक्टर मजरी अदर काजी साहब बहुत अच्छे हमारे वेरी सीनियर ऑप्थेल्मोलॉजिस्ट आप अपना एक्सपीरियंस भी शेयर कीजिए इस पे
ये सर माइक भी है
ठीक है और इसमें थोड़ा सा मैं ऐड करूँगा ऐसे केस हो जाते हैं हमारे साथ वी रेंट कैन एक्सीड बियॉन्ड द इक्वेटर एंड इफ देयर इज़ नो विट्रियस आइडियली वंस वी हैव डन जो मैस्मरी बताया वंस वी हैव डन क्लीनेस ऑफ द लेंस कैप्सूल एंड लेंस मैटर द वे ही डिड व्हेन वी इम्प्लांट द लेंस फर्स्ट फिल द chamber well with viscoelastic, place the lens and open the lens in the anterior chamber preferably. Open the anterior chamber and then gradually with the help of your Sinsky and other hooks and dialers etc. dial it to a place where you find maximum capsule stability is there. And once it is there in the bag, not in the bag, it is behind the iris I mean, then try to find that you can place the haptic in the sulcus and optic in the bag. It is not difficult if people is well dilated. But if the vitreous is there, preferably as much as possible you take out the vitreous before implanting the lens. Vitreous should be clear because it creates a lot of problem, and it will not let the lens stay in the posterior chamber. It will make it go too posteriorly, and that will create trouble. Now I will ask your experience. But experience है माशाल्लाह.
Normally, what I do is I just puncture the capsule, and try to reduce the intralentricular pressure, and then extend this. And in this scenario, I would like to ask you, what caution do you take to avoid Argentinian sign?
That's a very valid comment. And for puncturing, even you can use a straight 27 or 30 gauge needle. You may not use the cystitome. Just go there and nick it and let the milk ooze out. That's one thing. Second, if you feel that it's too swollen, a lens with a lot of endolenticular pressure, injection mannitol has been found to be quite useful preoperatively in those situations. And the third thing is, if you want to initiate the rhexis, you need to be a little quick. As soon as you are able to convert that nick into rhexis, then you are safe. The tendency to extend is there till your cut is linear. If you are able to nick and convert it into everted flap, the tendency to rip will be minimized. And the second thing, I come again and again, don't let your AC get shallow. If you have to alternate the instruments, you have to come out, you have to come again, keep the anterior chamber deep. And please don't use Simcoe cannula to aspirate the milk, because if you use Simcoe cannula to aspirate the milk, the AC will tend to get shallow, and the ample chances will be there in a shallow AC that the rip will extend.
Yes.
You need to visco express the milk out of anterior chamber. It comes more, use more visco, and keep on using your visco and keep the chamber deep till the contour is flattened and an anterior surface of the grayish brown lens becomes visible to you to proceed with the rhexis. The second thing is that keep the bag inflated as well, because once the milk has been expressed, the nucleus is small. So keep on moving the nucleus behind the rhexis, where you are applying your shearing force. It should be cushioned by the nucleus on its back. So keep on moving the nucleus along with the rhexis, because there will be no cushion between the anterior capsule and the posterior capsule because of the small size of the nucleus, and the nucleus keeps on moving.
So yes, nucleus keeps on fluttering actually over there. You can fill the gap, this gap now, intracapsular gap with the viscoelastic, and then you take the utrata, and then you can make it enlarge as the size you want. It is your own.
Mic pe
I want to share my experience. Dr. Saab has explained they puncture the capsule. I do beyond this. I suck the milk of the material with the same syringe, and almost all milk can be expressed out with the suction. Now the endo lens pressure goes bilkul extremely down, and then fill the anterior chamber with visco. Then always I use the utrata, because I think utrata has a good hold on the capsular axis. With this technique, I never got a rip or capsule rexes going out.
Shan, that's a very good tip. You can actually suck the milk out, and always Utrata is one of your best friends. I personally don't prefer Utrata as a routine rexis, though many of our colleagues are not in favor of needle assisted rexis. They use Utrata, and they are so quick. By the time we are preparing our cystitome, they have already done the rexis with Utrata. But you have to be well versed with Utrata in such situations, because definitely to convert it into D or to complete it, because there is no cushion of nucleus behind, you will definitely need McPherson or Utrata forceps at some stage. And as long as Utrata is concerned, you may invest a little more. There is 20 gauge vitreous forceps like Utrata available now, which operates like intravitreal forceps, and it goes through 20 gauge MVR incision or side port. And the difference between intravitreal instruments and anterior segment instrument, what should be the difference? कोई रेजिडेंट बताएगा कि जो इंट्राविट्रियल सीजर्स और फोर्सेप्स हैं उनको एंटीरियर चैम्बर में यूज़ करना क्यों मुश्किल है, क्यों नहीं कर सकते हम? और रेजिडेंट ने पूछा सी सर जी तो ये डॉक्टर ज़ीशान ने आपकी मुश्किल आसान कर दी है कि उनमें जो वो स्ट्रेट नेचर है वो मिड विट्रियस एंड बियॉन्ड ऑपरेट करने के लिए तो हेल्प करती है, लेकिन एंटीरियर सेगमेंट में, एंटीरियर चैम्बर में जिन चीज़ों को आपने ऑपरेट करना है, दे हैव टू बी आइदर कर्व्ड और एंगल्ड, ताकि आपका जो ब्रो है और जो आई का एनाटमी है, आपका इंस्ट्रूमेंट जब आँख के अंदर जाए तो वो आपके हाथ को बहुत ज़्यादा डाउन किए बगैर बाहर वाले इंस्ट्रूमेंट को, बाहर तो इंस्ट्रूमेंट वर्टिकल हो लेकिन आई में एंट्री आयरस के पैरेलल हो. तो दिस इज़ वन बिग डिफरेंस विच रेजिडेंट्स नीड टू अंडरस्टैंड एज वेल कि जो हॉरिजॉन्टल एंट्रीज़ के हम आदी होते हैं, तो जब कभी कोई यंग रेजिडेंट कभी कभी जो लेंस के अंदर इंजेक्शन लगा देते हैं वेस्टिन, तो दे फेल टू अंडरस्टैंड कि इंट्राविट्रियल एंट्रीज are directed towards the center of the vitreous cavity, towards the optic nerve head, whereas anterior chamber entries are initially towards the iris. As soon as the instrument is visible in the anterior chamber, you make it parallel to the iris. You enter towards the iris, but without touching the iris, you get parallel to the iris. So that beautiful Utrata forceps, which I am mentioning, it operates like intravitreal forceps, but it is curved. So that can be of real tool in pediatric cataract as well as hypermature milky cataracts or in calcified capsules, because it will not let your anterior chamber collapse. You can work through an MVR blade incision or a 15-degree incision very easily. It will be just plugging that gap and no visco will leak. Sir, comment करें?
Yeah,
Enough.
you have done everything. Now your second video, please.
Alhamdulillah. हमारे जो यहाँ पे रेजिडेंट बैठे हैं, they are allowed to ask whatever they want. We will not laugh. We will try to explain, because this is a rare opportunity to have this much of time as we have today. इस कैटरैक्ट के बारे में आपका क्या ख्याल है? क्या है ये? इसकी लुक क्या बता रही है? पोलर है, पोलर है। इसकी लुक बता रही है कि इसके पोलर होने का इम्कान बहुत ज़्यादा है, और इसका फ़ैसला तो आप हकीकतन स्ट्रेट लैंप पे कर सकते हैं, लेकिन बहरहाल माइक्रोस्कोप पे भी आपको फ़ौरन पता चल जाता है कि ये जो, तो जब आप ये देखें तो व्हाट आर द प्रिकॉशंस, व्हाट आर द थिंग्स विच शुड रन इन योर माइंड। ये इधर एक ग्रुप हमारा यंगस्टर्स का बैठा हुआ है, तो उनको भी साथ साथ लेके चलना है ना हमें। एनीवन? अक्सर ये जो पोस्टीरियर पोलर कैटरैक्ट्स हैं, ये उसकी किसी, आ जाएं आप, कंजेनिटल प्रीडिस्पोजिशन की वजह से पैदा होते हैं। इस माइक पे आ जाएं। और उसमें it is many a times it is accompanied by posterior capsular defects.
जो प्रिकॉशंस हम लेते हैं उसमें एक तो बोटल हाइट लो होना चाहिए सर, और रेक्सिस बोटल हाइट शुड बी लो, और रेक्सिस जो लेते हैं रेक्सिस शुड बी लार्ज एंड
कितना लार्ज करें?
5.5 mm या 6 mm।
वही तो स्टैंडर्ड साइज है।
स्टैंडर्ड है बेटा।
आपने 6 से बड़ा नहीं करना और 5.5 से छोटा नहीं करना। दैट्स द स्टैंडर्ड थिंग यू डू। और क्योंकि बहुत ज़्यादा बड़ा करेंगे तो फिर आप कैप्चर नहीं कर पाएंगे आप, जिसकी इस केस में ज़रूरत पड़ सकती है आपको। और
डू द हाइड्रोडिलिनेशन इंस्टेड ऑफ हाइड्रोडाइसेक्शन।
ये बहुत अच्छी बात इन्होंने की है। हाइड्रोडाइसेक्शन इज कंट्राइंडिकेटेड इन दीज केसेस। यू स्ट्रेट अवे गो फॉर हाइड्रोडिलिनिएशन। और वो करना इसलिए भी आसान है कि देखें उस सेंट्रल टिक्की के अलावा सारा जो लेंस है वो क्लियर है। यार इधर शो नहीं हो रही। हाँ,
इसमें हाइड्रोडाइसेक्शन तो नहीं करते, बट विद द हाइड्रोडाइसेक्शन कैनुला यू कैन जस्ट मेक मूवमेंट बिटवीन द कैप्सूल एंड द इक्वेटर on from both the sides, and you can separate it manually without hydrating it. इससे आपकी आसानी हो जाती है थोड़ी सी। देन हाइड्रोडिलिनेशन जैसे वो बता रहे हैं जी।
तो लेंस में भी कुछ सोचेंगे। ऐसे केस में लेंस कौन सा हमें अरेंज करना चाहिए? इसमें बहुत इम्कान है कि हम अपनी सारी महारत और कोशिश के बावजूद, इन स्पाइट ऑफ ऑल द एफर्ट्स, वी मे नॉट बी एबल टू इम्प्लांट द लेंस इन द बैग। तो इफ वी आर नॉट एबल टू इम्प्लांट द लेंस इन द बैग, तो कौन सा लेंस होना चाहिए? जहां मर्जी डाल दें IQ को या रेनर सिंगल पीस को, 3 पीस क्यों? वाई? वो तो आप किसी के भी डाल सकते हैं, हैप्टिक इन द सल्कस, वो तो सिंगल पीस के भी डाल जाएंगे। यू आर राइट, बट देयर इज अनदर कैच हियर। एनीबॉडी?
ये पूछना चाहते हैं कि पोस्टर कैप्सूल ही नहीं है, सारा खत्म हो गया आपका, तो फिर आप क्या करेंगे?
अब आपने लेंस को सल्कस में रखना है, उसमें एक बहुत बड़ा कंसर्न है। वो क्या है? स्क्वायर एज्ड जो लेंसेज हैं, जितने सिंगल पीस लेंसेज हैं, स्वाय रेनर सर्कोफ्लेक्स के, जो हमारे यहाँ अवेलेबल नहीं है, रेनर सर्कोफ्लेक्स, और जो स्फेरिकल लेंसेज हैं लाइक एक्रिसॉफ मल्टीपीस, लाइक होया मल्टीपीस, दे आर round edged lenses. Their optic has been finished in a round form, but all the single piece lenses, they come packed square edged. So if the lens is square edged, it is contraindicated for sulcus placement, because it will give rise to chafing of the square edge against the back surface of the iris, and there will be anterior chamber lens like release of pigment continuously, giving rise to chronic uveitis and glaucoma. So a very interesting study has been made by David Chang, and the guidelines have been issued by American Academy of Ophthalmology and American Society of Cataract and Refractive Surgery, that square edged lenses are contraindicated to be placed in the sulcus. Sometimes we don't have the backup. You can capture the optic and you can leave the haptics in the sulcus. तो मजबूरी की बात तो और है, लेकिन अगर आप प्लानिंग कर रहे हैं तो बेहतर ये है कि आप या तो बैकअप के तौर पर मल्टी पीस लेंथ ले लें, either you arrange the multi-piece lens as a backup option or you plan it as a primary option, क्योंकि उसने तो बैग में भी डल जाना है, सल्कस में भी डल जाना है, और खुदा न खास्ता कोई एक आध हैप्टिक स्क्लेरा में टांगना पड़ गया तो वो भी कर लेंगे हम.
जी बिल्कुल.
So we are doing everything as we do. So here comes Dr. Zishan's favorite instrument into play, Utrata's forceps. The only problem with Utrata is that anterior chamber can get shallow during the process. And if we have that Utrata I mentioned, that problem will not occur. Those are known as micro forceps, micro anterior segment forceps. This is hydrodelineation. The fluid current is being directly injected into the cortex, not below the capsule. So just teasing the nucleus a little bit and no dialing. Hydrodissection and dialing of the nucleus is contraindicated. Because there may be calcification at the posterior pole and the whole bag may rotate along with the nucleus. माशाल्लाह प्रोफेसर मजीद मलिक साहब जैसे एक्सपर्ट होंगे तो वो बात उगलवा के छोड़ेंगे. और ये हमारे प्रोफेसर साहब का बहुत फेवरेट टॉपिक है और कोई फुल मेरा ख्याल है 1 घंटे की एक इंस्ट्रक्शन कोर्स उनकी जंबील में पड़ा है सिर्फ पोस्टीरियर पोलर कैटरैक्ट पे. जंबील बड़े पुराने ज़माने का लफ्ज़ है, वो आपके लैपटॉप बैग जैसी कोई चीज़ होती थी.
आपकी उर्दू का मुकाबला नहीं कर सकते सर.
वो तो है फिर. दैट इज़ व्हाट मेक्स मी पोएट ऑप्थेल्मोलॉजिस्ट. तो ये सारा काम रूटीन के मुताबिक हो रहा है और इसका सबसे बड़ा इंग्रेडिएंट सब्र है, पेशेंस. ये आपकी रूटीन के मुताबिक वो चंद लम्हों में होने वाला काम नहीं है. विस्को इलास्टिक इज बीइंग यूज्ड एंड द होल soft nucleus has been very patiently kind of aspirated. No effort was made, no overzealous effort has been yet made to crack or rotate it. And even Simcoe is acting in slow motion, very slow, जैसे कोई दम सादे काम कर रहा हो. शीशागर ठहरे हैं हम, गिरे हैं शीशों की ज़िया, सांस रोक के दिल को थामे खोलते जाते हैं हम. वो देखें क्या हुआ है, व्हाट हैज़ हैपेंड. यूं ही वहाँ से वो आखिरी चांक उठाया है, वो ऐसे खुल गया है पीछे गैप. आपने देखा वो रेंट? इज इट विजिबल टू यू? इट्स जस्ट वर्टिकल बोर्ड शेप्ड गैप. जब आप कोई भी इंस्ट्रूमेंट अंदर लेके जाते हैं, विस्को इंजेक्ट करते हैं तो वो छोटा हो जाता है, लेकिन जब एसी शैलो होने लगता है तो बड़ा हो जाता है. लेकिन लकीली vitreous has not prolapsed in the anterior chamber. So after inflating the bag, we are placing the multi-piece IOL in the sulcus. And you see, this is capturing. The optic has been captured in the beneath the anterior capsule, and while removing the viscoelastic, the Symp keep on giving cushion to the IOL. Everything is performed in a slow motion, even slower than a regular cataract surgery. So with these precautions, without performing anterior vitrectomy, we were able to complete sulcus placement of the IOL. तो इसके बारे में भी आप कोई कमेंट और क्वेश्चन हो तो यू आर वेलकम. वो इसलिए कंफर्म है कि वो नहीं है एंटीरियर चैम्बर में. If it is there in the anterior chamber, it will never let your lens get centered. Or the moment you inject viscoelastic, your rent becomes linear. वो ऐसे हो जाता है आपके सामने. जब आपका AC शैलो होता है तब वो खुलता है, जो ही आप AC को डीप करते हैं वो दोबारा लीनियर हो जाता है. That shows कि your anterior vitreous face is intact. और आप कैना कार्ड यूज़ कर सकते हैं, लेकिन कैना कार्ड उतना फ्रेंडली नहीं है जितना उसका तस्करा किया जाता है. एक तो वो चूँकि आपका विट्रियस फेस वो पार्टीशन हैज़ ऑलरेडी बिन ब्रोकन, तो वो उसके जो पार्टिकल विट्रियस में चले जाने हैं ना, वो महीनों पेशेंट को तंग करेंगे. और इंटरेस्टिंगली इंट्राविट्रियल कैना कार्ड very frequently gives rise to high IOP as compared to posterior subtenon injection. तो इसलिए हम जितना पहले उसकी प्रमोशन करते थे, हम मेडिकल रेटिना में भी इंट्राविट्रियल कैना कार्ड बहुत रेयरली यूज़ करते हैं. जब हमने उसको एंटीवैगफ थेरेपी से कपल करना हो तो वो इंजेक्टेड posterior subtenon. It's a great tool which is not recognized by ophthalmic community yet. If the macular edema is not responding to regular anti-VEGF therapy, before switching on to the next costly anti-VEGF, one should add posterior subtenon Canaccord. So that is a separate discussion. So in this case, हमारा विट्रियस फेस इंटैक्ट है और आप उसको रियलाइज कर सकते हैं कि वो इंटैक्ट है. और अगर वो विट्रियस एंटीरियर चैम्बर में प्रोलैप्स होगा तो आईओएल डालने से कंफर्म हो जाएगा. वो कभी भी आईओएल को इस तरह सेंटर में नहीं होने देगा. और जब आपने एक दफ़ा आईओएल डाल लिया है और उसको सेंटर कर लिया है और चैम्बर इज़ डीप, तो देयर इज़ नो नीड टू यूज़ मायोकॉल, बिकॉज it is not whatever situation you give, and at the end of the surgery leave the eye tense as we routinely do. And if you are very touchy and very careful, inject the air bubble, a uniform air bubble in anterior chamber, and the IOP at the end of the surgery should be around 20 plus. Then the dynamics will not change. There is no way that the vitreous can come and get entrapped into your wound. It will happen only if you leave the eye soft. So never leave the eye soft. It's always risky. If you leave the eye soft, you are not using the valvular impact of the incision. The valvular sealing of the incision will come into play only if you raise intraocular pressure above certain level. Only then the posterior lip of the incision will seal tightly against the anterior lip of the incision. So the tendency in all the anterior segment surgeries is leave the eye tense. So this is not an issue in this case. तो आपकी हसरत अभी पूरी कर देते हैं. There is a next clip coming on. Stay with us. We'll be there shortly. और कोई कमेंट है? जी सर, प्लीज इधर माइक पे बताएं.
Is there any difference between the diopter of the lens when placing in the sulcus?
नो. वो तो अगर आपका कोई पीडियाट्रिक कैटरैक्ट हो तो उसमें दैट कम्स इनटू प्ले.
As it is placed anterior.
बड़ी आंख में तो कुछ नहीं होता. वो माइक्रोथैल्मिया में प्रॉब्लम है.
नहीं, इनका पॉइंट 30 तक वैलिड है. Power of lens slightly increases placing in the anterior chamber, so you should manage it accordingly. You should reduce the lens power to be implanted. Thank you. One diopter or so. जी, thank you.
ये सल्कस और बैग में वी डोंट चेंज द पावर.
थैंक यू सर.
एक और भी है अभी क्लिप.
आपको तो बराबर बुलाएंगे आप.
चलें, अल्हम्दुलिल्लाह.
Thank you, my dear colleagues. You have made our morning wonderful by honoring us with so many of friends here in the session. Mazari Sahab has done a lot and compensated for the deficiency of our presenters. My topic is similar. It is a case of posterior polar cataract, and while going to the posterior capsule, you can sometime accidentally or by nature of the capsule you can get a rent. How to move on with this situation? ये वाला है? जी, पहले हमें पता होना चाहिए what is definition of posterior polar cataract. Many people have their own understanding. A posterior polar cataract is a round, discoid, opaque mass composed of malformed and distorted lens fibers located in the central posterior part of the lens, close to and frequently adherent to the posterior capsule. And sometimes anterior vitreous phase is also adherent to this complex. So it becomes very easily ruptured during surgery. We should have a lot of care for that. So this is a video. Now, I have edited this video. The typical posterior polar cataract patient. I have cut short all the previous sessions starting from rexes, capsular clearance. Now I am going just to capsule. Peripheral cortical lens matter is there and only posterior capsule is there. So while doing capsule cleaning over there, why I held it? Because I saw rent. Now I went to Lumera mode and then you can see the rent. This is the rent. इसका यह वो ग्रीन वाला था एक आपका पॉइंटर. ये वाला ही है. नहीं यार. कौन सा है? दवाई रखना है इसको. अच्छा ये वाला ठीक. सो अब इसमें देखिएगा. Just I edited all the steps except the capsule and cortex. Now once we are here, there is a rent. You will shift into Lumera mode and you will see the rent very clearly. And now hold it there. We have an attempt to just take it out and then vitreous comes along with it. So keep the tip over there, go from the side port and inject viscoelastic, heavy viscoelastic, cohesive, fill well the chamber. Then, as Dr. Mazari has discussed, dry clearance of the lens matter with Simco. Visco already in place, we can inject visco from the other port. And gradually with very low flow take out the lens matter. you will see rent is not increasing in size and there is no vitreous coming out. Rent is there. You can see the rent. There is elliptical rent over there, standing like that. Because of frequent viscofilling, rent remains the same size. You can see the rent. That is the rent here. यार क्या होता है इसमें? एंड नहीं हुआ था इसमें जो था ना आपका इसमें यार पॉइंटर जो मैं बता रहा था आपको आपने बस उस वक्त जो ही विटनेस रेंट आपको फील होता है जस्ट डोंट होता है जब मैं निकॉलम फॉरन बाय विस्कुलर उससे कीप द पोर्ट ओवर देयर इट विल प्रिवेंट विटनेस कमिंग आउट होल्ड कर लिया यहाँ पे एंड देन ग्रेजुअली फिल इट फ्रॉम द अदर साइड ये चीज़ें खुद ही हो रही हैं आप वोट करें ये रेंट अब नज़र आ रहा है आपको बिल्कुल एलिप्टिकल दरमियान में फिल द विट्रियस एंटीरियर पार्ट ऑफ द रेंट कम्प्लीटली आपको सारा लेंस मेट्रोपिकली नज़र आ रहा है यू कैन सी इट अराउंड इसके बाद प्रेजेंटेशन है किरवाई साहब की एट ऑल लेवल्स I mean, when rent appears at all levels, starting from your capsulorhexis till nucleus clearing, till capsular clearance and everything. So gradually you clear the cortex by very slow motion activity, keeping the depth of anterior chamber intact. Keep other port intact and keep filling the anterior chamber. Don't देख कितना खूबसूरत नज़र आ रहा है आपको बीच में रेंट आपको but it is not increasing in size. It is very stable. There is no vitreous prolapse. Now from the other hand, you can use this part of the cortex. Idea is to keep the anterior chamber well formed and deep, not allowing it to get shallow, otherwise the rent will spread and increase and there is always risk of vitreous prolapsing. Now it is well filled and now the time for implanting IOL. IOL is generally multi-piece. Very gradually leading haptic is already in the sulcus. Dilate and then slightly push it that the optic goes into the bag and you can see here the haptic in the sulcus. If you want to consider the pupil to make it beautiful, it is good. I generally use this, once I'm sure that there is no vitreous phase broken, you can inject triamcinolone and for dual purpose, to reduce inflammation and to find any trace of vitreous to be taken out. Thank you very much. Any comment? I will request Dr. Kidwai to come up with the beautiful presentation of managing it at all levels. Thank you. In such, we have to rotate the lens, and the optics are in the sulcus. We are not worried about it. Lens bag should ideally be within the bag. You should press and gradually place the optic under the capsular edges. Haptic should be in the sulcus, ideally, because if something goes wrong anywhere in future, entire assembly or lens does not slip out of that. That is the idea. Thank you.
Which OVD do you use in this case particularly, or we should use HPMC or sodium hyaluronate? Which is ideal?
Sodium hyaluronate.
Sodium hyaluronate.
So, and even in that, it is preferable, provis करते हैं प्रैक्टिकल मैं आप नाम ही ले लूँ क्योंकि उसमें it keeps it pressed against all odds and it comes and blocks when you take it out. You don't leave any trace of it and that will not raise pressure, that will not make the lens slippery. That comes out and block. Thank you.
But if the luxury OVDs are not available, please don't get depressed. Follow the principles. Methyl cellulose will also serve the purpose.
He pointed on me.
अच्छा आदमी मैंने कहा इसमें नाराज न करिए अच्छा कौन-सी का बुलाने से टुकड़ों को राज करने के लिए
Assalamu alaikum everyone, good morning again. It's the most difficult session in terms of the last day of the conference. Everyone's tired, but I'm really impressed with the attendance, even it's the last day. And I'm really grateful for all the organizers, especially Brigadier Majid, for arranging such a beautiful conference and very, very useful scientific data.
Thank you.
So basically, we're going to try and go through, please stop me when we're running out of the time, but we got lots of videos and I'll try to show you step-by-step approach. The objective is for the junior doctors as well to learn what the classical teaching is. If you come across a rent, what's your classical teaching is. You might get away with lots of problems, but you should know the classical teaching because this is what they're going to ask you in the exams. So this is just a brief introduction of myself. I work as a consultant in Karachi, returned from UK last year. So almost a year and a half working in Pakistan so far. So this is the basic thing. So when you can have PC rupture or a thing that is preceding to PC rupture at any stage of your cataract surgery. And these are the basic principles that you should remember. Number one is you have to recognize the problem. If your rexus is extending, you have to recognize that it is extending. And then get out of the denial. This is the first thing that comes up in our mind. We've got a big list behind us. We have to finish on time. Your technician is shouting at you. You're running late and stuff like that. But don't get all those things in your head. I think it's not that thing and I can get away with it. No, if it's something that looks odd, think that it is odd, okay? Get out of the denial because that's going to cause you more problem. If you deny that and if it is that thing, then you will be in deep trouble, okay? And then other thing is everyone comes across PC rupture and these complications. The only one who doesn't come across is the one who doesn't operate at all. So you will come across these problems and more you operate, you will come across more and more on these things. So keep calm, okay? That's the main thing. You don't come across PC rupture as you get senior, but you might get rusty in your management of PC rupture, but you will still get PC ruptures. And the next thing is, if you get the tear in AC, avoid tear extension. If you get tear in PC, avoid further extension of your PC rupture. And the key principle, as Brigadier Majid very nicely demonstrated, that when there is posterior polar cataract and there is posterior capsular rupture, when you are bringing your probe out, before that you insert OVDs, ideally viscoat, but by the time you call viscoat, it's in the fridge, and you just insert something in it. It works like a wall, and it prevents vitreous loss, and that's the basic principle. And avoid nucleus drop by doing certain things, and recognizing when you have to do it, okay?
And a very important point that's been already discussed, that IOL insertion is essential. You don't want to put single piece IOL in sulcus, okay? I'm primarily a glaucoma surgeon, and you know that I've seen lots of patients coming up with UGH, and they've got uncontrolled IOP, and many of these patients ended up having trabeculectomy because they are refractory glaucomas. So don't do that. You might get away with it. Patient will be fine, 6 for maybe 6 months, but then they'll keep bouncing into different clinics and with high pressures and glaucoma. So don't do that, please. So never ever insert a single piece in sulcus. It's absolute no-no. And then you always think about single piece and multi-piece options. So why we fear PC rupture? Because it increases the risk of retinal detachment significantly, and that's why we don't want vitreous prolapse. And it increases significantly endophthalmitis risk, and it also predisposes patients to CMO development after surgery. So the key questions that you need to ask yourself whenever, at every stage you're going to go through, I'm going to show you surgeries on every stages, complications on every stages, but the key questions you need to ask yourself, or the seniors, is what should I do? Should I continue Phaco, or shall I convert at this stage to ECI? You have no idea how blessed we are working in these circumstances, and we all have exposures of ECI. ECI is still a beautiful surgery and salvages you from lots of trouble. So you keep your skills on with ECI. Don't lose it. It can still save you in lots of difficult cases. There is no holy book written on that which says that you should definitely do a Phaco on a case. If it's appropriate to do ECI on that case, do ECI on that case rather than going Phaco for every case. So ECI or Phaco, that's the basic question. Then you move forward. Other questions you can ask is, shall I insert the IOL? If you've got a bad PC, you are struggling, you had a vitrectomy in all these cases, do you definitely need to insert IOL on that case? That's another question you need to ask, okay? Because you can sometimes get into more trouble by inserting IOL in that case. There is no harm doing a secondary IOL insertion, okay? When eye is much quieter, 3 weeks later, 4 weeks later, you will have much smoother environment to go in, put a reasonable IOL, and then you will be happy. And the third question that you need to ask is, you know, whether you want to put a small piece IOL. If you are putting a small piece IOL, you are risking that it can drop back into the vitreous because it can only go in the back if there is PC rupture. And the other question, safer option would be multi-piece IOL. Okay, can we go to the other presentation, please? Yeah, the UQ one here. That's the UQ. So let's deep dive in. So this is case number 1. We've already discussed a lot about this, but this is something you're going to come across a lot, okay? So insertion, normal looking rex is going on. Then you see suddenly, as has been pointed out initially in this session, you know, AC collapsed and then rexus goes out. So the key learning point is never let AC collapse. And the surgeon kept on doing regularly without any modification in the technique. And looks what happens. So surgeon was in a denial, okay? So it looks what happens. Boom, okay? And this is what we don't want to see. Because this is out, because I'm an anterior segment surgeon and I feel embarrassed asking posterior segment surgeons to help me in this, okay? And it's always be the case. But I want to salvage it before that. So another similar case, Argentinian flag has been discussed earlier, but this is boom. The thing is, what I wanted to say, it doesn't give you much time. It just gives, it's a fraction of a second, it's boom, it's out of your hand suddenly. So this is really important. First of all, if you're dealing with these cases, they are really high risk cases, okay? Always a white cataract is a high risk case. So always think about what you can do. So at this point, what's happened, the question that comes up in mind is, shall I continue as a Phaco with modification, obviously? Because if I don't modify, it will end up like what I just showed you. Or shall I convert into Eki at this point? Most of the surgeons would prefer to go for Phaco because we are mostly Phaco surgeons. And this is one of the techniques of doing it. Already a lot being discussed. So I like using bimanual IA. And all those people who use Simco, I would recommend you strongly, just try using bimanual on your one list. And I can guarantee you 90% of you won't go back to Simco again. Because it gives you such a beautiful control in AC. What we did in this case is just we sucked out the loose cortex, and it just reduces the pressure under the capsule significantly and avoids further extension. And then you just give 2 nicks superiorly, inferiorly, and then extends the raxis further. One thing you must always remember in these cases, you don't do hydrodissection in these cases. Hydrodissection is no-no when your raxis is extended. You need hydrodelineation in these cases to help you remove as much as you can. So in these hard cases, hydrodelineation is very, very difficult, but you still leave a little bit of frame near the capsule that saves you. And the second tip is, when you are cracking on these, try to avoid the equatorial extensions where it actually extended. So avoid these areas where it extended. So look at that. The cracking is done vertically away from those areas, okay? If you manipulate in these areas, it will extend and it will drop. So we've already done a lot of discussion on Argentinian flag, so I would like to go forward. Now, this has been discussed as well, how to avoid this. So I like this technique, which is very, very useful. So instead of doing anything, put a lot of viscoelastic. You need a good fill of viscoelastic. That's the key. Rule number 1. Directly go with either 25 gauge or 27 gauge needle straight into the AC, into the rupture the capsule into the lens, and then suck it out. You can suck out a lot in this way. And you will notice that the nucleus, remaining nucleus, will start moving again. You can go back again if you want to by filling up a little bit of viscoelastic more on it. And that just reduces the probability of Argentinian flag significantly. It's the cheapest technique you can go with, and it's much safer and helps you prevent Argentinian flag. Now, another interesting thing, a gadget that's been in the horizon recently and been popularized a lot in the West, is this thing. It's called Zepto. I know it's not available in Pakistan, but until and unless we see an innovation, we would never want to have it, okay? So this is an ultrasonic device. It's like the device, the machine itself is like a size of an Ortlieb machine. It's connected with this port. It goes in through 2.2 incision easily, and then it attaches with the anterior capsule. And then a special suction develops with ultrasonic induction. Boom. So it just creates beautifully well circumscribed. The manufacturers are arguing to use it on every case. I know this is not possible, but for these cases, it has its utility. And you know, there has been a debate going on for last 15 years about femto-assisted laser surgeries, femto-assisted cataract surgeries. And these are the cases where I think femto-assisted cataract surgery would be useful as well, because it creates the flap. Argentinian flag will be a disaster in these cases. We can run away with it, but not always. Okay, so let's move on to step number 2, which is hydrodissection. Normally we do it regularly, but now this is very interesting. So if you look at the case, good rexus, and then this is the hydrodissection cannula, 27 gauge, and then boom. Did you see that? Boom. So that's the pupil snap sign over there. This is something that they ask regularly in the exams as well. And this is the point where we go on the maximum denial. Nothing happened. Maybe I'll get away with it. It's stuck. Maybe I'll try more hydrodissection at that point. But look at what surgeon did. Keep trying to rotate the lens, attempting more and more hydrodissection. Although there was an obvious pupil snap sign in the beginning. Bye-bye. So it has gone down. It has stopped. Sorry. So this is, again, if you see a pupil snap sign, what to do again? The same question. Shall I continue with Phaco? Or shall I modify my technique with Phaco? Or shall I just convert it at this point? Interestingly, we did a similar session a few months ago, and we had like finest cataract surgeons. And this is the only point where even some of the vitreoretina surgeons agreed that we should consider converting it into ECI. Okay? Maybe many modern surgeons might disagree with me, but if you are sure that this is a pupil snap sign and it's not rotating at all, then it's better to avoid this complication much easily at this point if it's a significant amount of cataract. If to continue with Phaco, so let's have a look at this another case. So this is again a nicely managed case in which they continued with Phaco, but they took all the lens material out into the AC before they put the probe in, because probe is a high pressure probe and it will lead to a sudden drop of the remaining lens matter. So they nicely brought the nucleus out into the anterior capsule, over the anterior capsule, and then took it out with the Phaco probe. So at this point, I would be really interested, because this is an interactive session. So I would be really interested if you can just raise the hands. How many of you, if you come across pupil snap sign, would still continue with Phaco? So I assume no one will continue with Phaco at that point, and everyone will convert into ECI. Agreed? So if I ask again, at this pupil snap sign, looking at obvious pupil snap sign, non-rotating nucleus, you will convert into ECI at that point. If you agree, can you raise your hands, please? So I'm not sure what the rest of you think. So yeah, very few hands were raised for ECI, but nobody raised hand for Phaco either. So yeah, that's a difficult circumstances. Okay, so let's move on to step number 3, which is sculpting. I still like doing divide and conquer technique, which is more like a textbook technique, but it could be the similar circumstances with stop and chop. Okay, so let's go through with this case. Routine sculpting, looks like a routine sculpting, going on and on, on and on, on and on, on and on, and then, something's coming up. Boom. Okay. So there's some, so again, this is a difficult circumstance. So what to do at this point? Anyone, any suggestion? Sorry?
This is known as buttonhole sign, as you can see in the center. So buttonhole sign is a very great indication that you have kissed the capsule. So now the same technique may be applied. You can use OVD and bring the nucleus into the anterior chamber, and you can cushion the PC and the vitreous with OVD. You may continue, but you must realize the buttonhole sign and must realize that there is a central compromise in the posterior capsule. Great possibility. Sometimes you are lucky, but don't deny it. Sometimes only if such a sign appears, maybe 1 out of 10 cases, you are still safe. and you have not kissed the PC yet, but in most of the times you have rented it. So if you keep that thing in mind and modify your technique accordingly, you can continue with Phaco.
Perfect. So this is the same circumstances again. So please remember those principles, all of them. Again, as Professor Mazhar said, that come out of the denial. It's PC rupture in front of you. Okay. And now what you need to do is avoid vitreous loss and avoid dropping the nucleus. These are the two principal things that you want here. And then you'll think about whether there is you can implant the lens or not. Okay. So step-by-step approach. Keep calm, and this is what you need to do. But let's see, again, the same question, because we are good ECI surgeons, why not convert this patient to ECI? But yes, you can try continuing Phaco. And most of the, I think most of you would agree that Phaco, we will try and do Phaco in these cases, but with modified technique. So this patient was continued with Phaco. Again, denial on the top. But you need to modify the technique drastically here. But look at the mistakes done. Trying to do divide and conquer with a PC rupture just behind it is absolute no-no. That goes, okay? So number 1 goes, number 2 goes, and number 3 goes, okay? So half of the nucleus is down. And then step number 2, made a big mistake again here. All the juniors, this is again an absolute no-no. You don't want to take out your second instrument, or your first instrument without putting something in, okay? So what he did is taken out the second instrument. Now let's see. Sorry, I just my apologies, I have to play it again, sorry. So again, sorry, I'm just replaying it because I just lost it. The video was lost for some reason. So divide and conquer attempted, which was wrong. As Brigadier Majid has rightly pointed out, and now this is a PC rupture there. The thing that I wanted to point out is whenever you are doing this, this mistake is done. They shouldn't have rotated it. They shouldn't have. They shouldn't have divided it further, and as a result, it has dropped down at the back. Now, the second thing that you need to avoid here is before you take this instrument out, you want to put a lot of viscoelastic here, okay? Otherwise, one of the principles is we want to avoid vitreous loss. Whatever is gone behind is gone, okay? But we still don't want enough vitreous loss, okay? So you have to, from this end, the second instrument came out. Before you do anything, you want to insert an OVD in here and put loads of OVD there. And that will help you, give you a cushion. So look at that. Dropped 1, second, third. It's all going down one by one. Look at that. This is the ideal technique. This is the classical teaching that you need to do. So whenever you have PC rupture, do not take your probe out. Never take your probe out until and unless you put enough viscoelastic in, okay? This viscoelastic works in 2 ways. Number 1, it keeps the AC formed, so there is no space for vitreous to come. And secondly, if you use a dispersive viscoelastic such as Viscoat, no financial disclosure, but that also works like a wall, and it prevents from it coming forward, okay? But this is an absolute thing you need to know whenever, at every step you come across vitreous loss, and Brigadier Majid has rightly pointed out in posterior polar management. So after this you can remove the remaining by your second instrument and bring it above the anterior capsule and take it out by enlarging the wound, okay? If you take the probe back in at this point, it will drop back again because the pressure of the inflow is too much and the viscoelastic won't hold it. But viscoelastic will give you a cushion to the point till you can take those remaining pieces out above the anterior capsule and take it out by enlarging the lens, enlarging the wound. So like a partial conversion to Ecce. This can also happen in cord removal, and which is the same as when you're doing divide and conquer techniques. So the problem here is the tip is really ahead, okay? It's against the phaco-dynamics principles to take the tip that far, because you must remember the lens is like a bowl, okay? The equatorial parts are very shallow and you can easily touch the capsule on the equatorial part. So you don't want to bring your probe as far in the periphery as this person has, and as a result there was a PC rupture there. Again the same question, but yeah, most of us will agree to go ahead with phaco with slight modification. And again the same thing that you need to remember. They continue doing it with the denial without realizing that there is PC rupture. And look at that, the cortical matter is going back into the vitreous. PC rupture, big PC tear. Okay? Now, we move on to irrigation and aspiration. I've put one video for Simco because I know most of us still use Simco here. So this is, with Simco, the most painful piece to take out is the subincisional. And you can see the wrinkles just happen. And at that point, PC rupture has occurred, okay? You might see it in a minute when it gets a bit larger. Again, I would like to ask this question to our audience. Please raise your hands if you use bimanual IA. Okay. So it seems like 99% of us are using Simco cannula, okay? I'm not saying I'm best surgeon or anything, but honestly, with my life experience, I have used Simco cannula for 7-8 years. And then I was forced by my trainers to move on to bimanual IA. I didn't like it for the first thing, but after one day, I don't think so I ever want to go back to Simco cannula. You can argue the usage, but there are autoclavable bimanual IAs easily available, and you will love it. The control that it gives you is beautiful. So please do try it once if you haven't tried it before.
I use all three, coaxial, bimanual, as well as Simco.
Perfect.
All of them serve the purpose.
Absolutely.
There's a beauty about the coaxial, that you don't need extra port, you don't need to enlarge your side port. It goes through the same phaco and CN. But all of them have little pros and cons. But this is a beauty because during IA, by using this automated cannula assisted machine operated irrigation aspiration, you get the advantages of all the phaco-dynamics, of all the softwares of maintenance of the anterior chamber, keeping the capsular bag inflated throughout distended. So those are the beauties with this automated IA.
Yes, that's rightly said. Everything has got its own pros and cons. Okay, so at this point, this is the Simco. You can see. When you see this a spider web sign, you are in trouble most of the time. Unless you're using those coaxials with silicone tip. You can pull PC with that and it doesn't rupture, but anything else, it just ruptures. So this surgeon did a smart thing. It made it circumlinear, the tear. And you can do that if PC rupture is in IA and you've removed enough of the cortical meta. And then it's well controlled and you can implant a single piece IOL in the bag after that. But if you don't want to try it, don't worry. You don't need to learn this technique either.
I think you converted it into a little rexes very quickly. The audience may have not noticed. That's a great trick. That if there is a local rent, just convert it into a little rexes. Then it will not extend. Just make it round with the help of your ultra forceps. That's what the surgeon did in this case. And then he cushioned it with OVD and completed the case.
Exactly. So for juniors, you must remember that if the PC rupture is normally not curvilinear, okay? So it has these sharp edges which extends, okay? But if it's curvilinear, like anterior capsulotomy that we do, then it doesn't extend. So then you can easily, so for one of the conditions that if you want to implant single piece after PC rupture, then you should have a curvilinear rexus, because otherwise it will extend even after implantation of the IOL. And pediatric patients, when we do the posterior capsulotomy, some people do it regularly. So this is what I use, bimanual IA. You can get PC rupture with bimanual IA as well. I'm not sure why it's not moving. Okay, let's move on to IOL implantation. I just wanted to highlight a fact that, so one of the questions that we have always in the mind, and we get in trouble when we are actually operating on a patient where we've promised to place toric lens or multifocal lens, especially torics, then we can get into trouble, and if there's a PC rupture. So again, you need to try and make it circumcurvilinear, do a good vitrectomy, and after that, if you still want to place it, you can't place it in the sulcus. But what you can do is do an iris capture, okay? You can place it either in the bag and then do the optic capture outside the bag, or you can place it in the sulcus but do the optic capture in the bag. So either way, this is the only possibility you can get away, but either the classical teaching and the recommendation is not to pull single piece in these cases. So we have moved on to IOL implantation. You can get PC rupture during IOL implantation. This is the time when you are more relaxed and you in fact start thinking about your next case, but you can still get into trouble in these cases, okay? Sometimes especially when you're using multiple different types of lenses in a single list, every other lens has got different injector capabilities, and you can get into this trouble suddenly. Sorry, in this, it's not very easily identifiable, but I'm not sure if you can see it, but sorry, this pointer is very difficult. So if you go through again, please look at the left-hand side temporally. You will see that there is a PC rupture. It is also possible that this hasn't happened during the IOL insertion. It was just before that in IA, but it's missed by the surgeon, but it's on this side. Okay? Let's go on and it will become more and more obvious. So the question here is, I'll show you that it is quite obvious, but now you know that you've inserted a single piece IOL, and now you can see a big PC rupture there, or let's say small PC rupture on one side. You've just noticed after insertion of the IOL. This can happen. So what should you do after that? My question is, would you leave it as it is, or would you remove it and place a multi-piece IOL? Shall I ask everyone? Anyone? Would you remove it? Yes? No. You leave it as
We will remove it only if multi-piece IOL is available.
Okay.
If we have the backup, only then we can remove it.
Yeah. In this case, we've opened up the IQ lens, which is very expensive. So IQ lens is inserted.
So
in the
the reality and the ground fact sometimes differ. The ideal thing is to remove it and implant the multi-piece IOL. But ideal sometimes are not possible to meet because you may not have it available.
Yes.
अगर ये दास्तां इतनी सादा होती ना तो फिर तो ठीक था, लेकिन ये बहुत मुमकिन है कि उस वक्त तो आप इस सिचुएशन को वर्स नहीं बना रहे, तो सम टाइम लेटर because of uveitis and glaucoma some other surgeon may have to take it out, but sometimes you are lucky because the dynamics of the bag and the sulcus are such that it's quite deep, and you are lucky that your IQ or the single piece lens is lying away from the iris and you don't get any issues. So that's why you get confident and you keep on doing that. But this is how the thing actually emerged, that there was a persistent uveitis and glaucoma in Singapore Eye Center. They noticed that what's happening with our single piece lenses, that the patients are coming with persistent uveitis and IOP. Then they had about 400 cases. They reviewed them retrospectively. And what they found out was that all that uveitis and glaucoma issues were detected in the patients who had been placed with an IOL in the sulcus. A single piece square edged IOL placed in the sulcus led to that complication. That's why this guideline has been issued. So one achieves something only if one desires to do that. If one needs to have an intention to do something first. If you intend to do it and you want to deliver it, then you will make it possible. If you don't think something is important or it's a complication, or it will induce the patient a certain problem, then you cannot fix it. If we think it, if we now admit that it's a problem and we have to fix it, only then we can find out a solution, and every center in the periphery or a trust or whatever, we can come up with the solutions. But we need to have a consensus here that the square-edged IOLs are contraindicated for the sulcus. That's one thing. What you do, let your center and yourself decide.
Dr. Kashif.
I have not negated, I already said that the ideals are not met.
जी प्लीज बेटा आप उधर चले जाएं सामने.
Dr. Kashif, I had the same situation about 10 years ago. The power of the IQ was about 7 to 8 diopters, and there was no backup lens available. So the patient was quite young, and the PC ruptured. And although it was a small lens at the side, so I implanted it into the sulcus, and it remained there. And I have seen the patient many times during these years. About I think 8-10 years have passed, and the patient is fine. But it should not be. If you have the choice, it should not be there. In this case, especially, I have seen that this IOL is in the bag, and there is a rent. And my belief is that once, if there is a rent and you have placed the lens into the bag, it will seal the hole. Yes. It will seal the hole, and the vitreous will not come out if you just take care that the vacuum, that IOP, that eye should not go into the hypotony. Just maintain the AC. It should not, if you maintain the pressure in the AC, the vitreous will not come out. Just take care of it, just do the vitrectomy, and there should be not vitreous which is just entangling the iris, and I think this case will work, the visual acuity will improve.
Do you agree to it?
Yes, Kashyap, I agree with you on several issues. As you are not there when there are presentation of Professor Mazari. If the lens is spheric and lens is not squared, you place the single piece lens in the posterior behind the posterior iris in front of the anterior capsule. That is the situation. No? These lenses don't bother much as compared to square eye lenses. One, they cause more problem of chafing and problem. Secondly, if the patient's eye color is lighter color eye with reddy blue or lighter color of iris, again the problem is less. In the dark color eye, you should never place lens, single piece lens in the in front of anterior capsule.
Let's shift back to the presentation.
Okay, coming back to
very nice points, but yes, the thing is, the classical teaching is, I don't have a scientific data to prove everything. None of us have, unfortunately. These are very rare cases and no one does it. But the classical teaching is, if there is a PC rupture, you can't leave single piece there. It will drop down. There's a significant risk it can drop down, okay? And patient can have more problems, okay? The classical teaching is to remove it, okay, but and put a multi-piece IOL. This is the classical teaching, okay. But in this case, as one of the colleagues rightly pointed out, if surgeon is quite sure and if they don't want to manipulate anything at all after this, leaving a lot of viscoelastic in the eye and just leave the eye as it is, which have its own consequences, this is one thing that they can try. But what this surgeon did, place the eye. Now you can see the tear. It's more visible. But this surgeon did is tried to manipulate and remove viscoelastic, again in the phase of denial. I think the biggest enemy for us is the denial. And then this got really unstable. So I agree with the honorable colleagues that yes, if you don't do anything, but you might not be able to, even if you leave a lot of viscoelastic in the bag, then there is a small possibility that you might get away with it. And this is why you can maybe attempt leaving it as it is. But my experience is, even if, extended anterior capsulotomy, and if you place single piece IOL, you see them a bit wobbly a week later. So they are a bit wobbly. So they are not very ideal in anything like that. But, sorry, I don't know what happened. It should work.
We are getting relatively short of time.
Okay.
The audience is waiting for the tea. So
Sure.
please speed up.
Okay, so just wanted to go through two quick techniques. Number one is when you have to remove the IOL, you need to cut it ideally again. Okay, so cut it in half with the special scissors, IOL cutting scissors, and then what you can do is, instead of cutting it in a half, you can just leave a little hinge. So when you pull out from one end, the other hinge will rotate the rest of the half and the whole lens will come out from the same incision. This is one way of removing the lens. The other one, I love this, so that's why I'm sharing it. You don't need to cut it. They are acrylic single piece IOLs made foldable. So put loads of viscoelastic on the cornea. Hold with McPherson's forceps and place the iris repositor on top of the lens, and then do a quick rotating movements with your wrist. That's it. So simple. I think that's it. Thank you so much for the opportunity. Thank you so much.
Thank you, Dr. Kidwai, for an excellent presentation on multiple aspects of problems that we encounter in cataract surgery. And that's all with the session. We have gone 15 minutes ahead of session despite having shortage of our speakers. Thank you very much for listening and for very interesting interaction and discussion on the subject. Yes? Question from?
Just one question.
Okay.
My question is that the surgeon who showed all the cases, they were mostly hypermature.
Mostly?
Mostly hypermature cases, either Morgaginian or with the hard nucleus. What I think, why we should not take proper decision before doing surgery, and why we shall take risk of these things. If the patient is not fit for Phaco, what I mean, so then we shall think to prevent from the complication. Isn't it much safer to do extra cap? What is the harm in it? Number one, this is my point.
अगर हम 98 out of 100 hypermature cases को Phaco कर सकते हैं, तो 100 का extra cap क्यों करें? वो 2 के लिए. तो वो complication तो extra cap में भी हो सकती है ना?
No sir, as far as the rate of complication is concerned in the normal, mature or below mature cataract, the complications of such a sort of complications are very less. Only chances of perforation is the posterior subcapsular cataract, which is quite adherent to the PC.
We partially agree to you, because the decision of planning an extra cap and Phaco depends upon your setup, the facilities you have, the kind of Phaco machine you have, and the kind of experience you have. It's an individual decision. There are no guidelines for that. If you don't feel confident, go for extra cap. But if you have enough experience and your equipment is good and you have all the accessories to help out, then it's your individual decision to consider Phaco or extra
point
cap.
is, benefit of the patients. When we feel it is risky for the patient.
If you feel risky, do extra cap.
Yes, yes.
For you only.
Okay. Thank you.
Thank you. Thank you very much. And thank you for patient handling of the case.